Distinguishing between a true aneurysm and a pseudoaneurysm or false aneurysm is a critical clinical task because their underlying pathology, risk of rupture, and urgency of treatment differ significantly. True aneurysm of the left ventricle can occur when the scar of myocardial infarction bulges out in chronic stage. Pseudoaneurysm of left ventricle is a rupture contained by pericardium. In case of arteries, true aneurysm occurs by gradual enlargement of a region due to weakening of the vessel wall. Arterial pseudoaneurysm is also a contained rupture. Vascular pseudoaneurysm can also develop after an arterial puncture which has not sealed off well. The primary difference between true and pseudoaneurysm of arteries lies in the integrity of the arterial wall layers, tunica intima, media, and adventitia. A true aneurysm involves all three layers of the vessel wall, while a pseudoaneurysm is a contained hematoma outside the wall, only covered by adventitia or surrounding tissue which forms the sac. True aneurysm is usually symmetrical, fusiform, or asymmetrical, saccular. Pseudoaneurysm is typically an eccentric round bulge with a narrow neck. On ultrasound imaging, dilated vessel will be seen with a layered thrombus occasionally. Characteristic yin-yang sign turbulent flow and to and fro spectral Doppler pattern can be seen in pseudoaneurysm. Width of the neck or neck to sac ratio is 0.5 to 0.9 in true aneurysm, while the neck is narrow, neck to sac ratio less than 0.5 in pseudoaneurysm. Atherosclerosis, hypertension, and genetic causes like Marfan syndrome are important causes of true arterial aneurysm, especially aneurysm of aorta. Trauma, iatrogenic injury during catheterization, and infection are important causes of arterial pseudoaneurysm. Similar to this, true aneurysm of the left ventricle also has all three layers: endocardium, myocardium, and pericardium, while pseudoaneurysm has only a pericardial layer. Structural weakness of a pseudoaneurysm makes it inherently more dangerous than a true aneurysm of same size. Arterial pseudoaneurysms lack the structural support of the muscular media layer. They have a significantly higher risk of spontaneous rupture. For instance, splenic artery pseudoaneurysm have a rupture risk as high as 37%, with mortality rates approaching 90% if untreated. Both types of aneurysms can harbor thrombi or clots, but the turbulent flow in a pseudoaneurysm often increases the risk of distal embolization, potentially leading to limb ischemia or organ damage in case of arterial aneurysms. Pseudoaneurysms caused by IV drug use or sepsis, known as mycotic pseudoaneurysms, can lead to rapid tissue destruction and systemic sepsis. Profile is similar for left ventricular pseudoaneurysm as well. Management strategy depends on the location and stability of the arterial lesions. For pseudoaneurysms, it has a higher urgency. Conservative management is only for very small, less than 2 cm asymptomatic femoral pseudoaneurysm. They may spontaneously thrombose and clot off. Ultrasound-guided thrombin injection is the gold standard for accessible peripheral pseudoaneurysm like that of femoral artery. A clotting agent is injected directly into the sac to seal it. Ultrasound-guided manual compression applied to the neck to stop flow until it clots is another option, but painful and less effective than thrombin. Endovascular or surgical repair are essential for visceral or aortic pseudoaneurysm. Options include coiling, stent grafts, or open surgical ligation depending on the location. Urgent surgical repair is needed for left ventricular pseudoaneurysm as there is a high risk of secondary rupture. For true arterial aneurysms, the repair is elective. Medical management focuses on blood pressure control with beta blockers and serial imaging, sometimes with watchful waiting. Surgery is typically elective and based on the size. Example, more than 5.5 cm for abdominal aortic aneurysm, the so-called AAA, or more than 2 cm for visceral aneurysms. In case of left ventricular true aneurysms, there is additional risk of heart failure and arrhythmias due to re-entrant circuit around the scar. Several methods of aneurysm repair have been described, though effectiveness varies due to significant coronary artery disease associated with left ventricular aneurysm.